Hey Darren, thank you so much for joining me today on the Business of Healthcare podcast. How are you doing?
Very good. Nice to see you again.
So, whereabouts in the world are you
We're South West Lincolnshire.
and what do you do?
I'm the CEO of K2 Healthcare, which is a federation of 16 GP practices, and within that we have two neighbourhoods or two PCNs. So our Grantham area and our Sleaford area. In my spare time as well, I'm the Director of Transformation for our PCN Alliance, which sees all of the 14 PCNs working together across Lincolnshire.
So let's just repeat that structure. So you are in a federation, 16 practices. When you said two PCNs, two neighbourhoods, are they the same or are they different?
They're the same. They're the same, and they should be. The PCN design was really around neighbourhoods, wasn't it? That health in neighbourhoods around groups of practices, that geography and delivering better services in those neighbourhoods. So we had neighbourhoods before we had PCN. So we made a federation to work together before, if you like, the mandate and the support that came with the mandate to work as PCNs.
Okay, so you've got your federation, and inside your federation, you've got 16 practices divided into two neighbourhoods, and you have is it a GP alliance? What's that?
Yeah, our PCN Alliance, which is 14 PCNs, all the PCNs, different shapes and sizes. Some federations within those working across Lincolnshire.
So I wanted to speak with you. Obviously, our paths have crossed. We've done some work together to think about the future. It's very timely. So whilst we're recording this in March, we've just had kind of direction regarding guidelines around neighbourhood health, and we've also had the GP contract letter. So let's start with the GP contract. When you first saw the letter and the changes that are did you think it was positive, negative? Is it business as usual? Like, what did you think?
All of those, and I'm still waiting to get a proper grasp of it and discuss that with our GP partners. So I haven't interrogated it greatly, and we're going to get around and see what it means for us as individual practices and for PCNs.
Financially, over the last year, has it been tough from a federation perspective?
More from an individual GP practice perspective than from a federation perspective. Tough from a federation perspective, I think, because we're in have been in some really different territory. We as a federation and a group of practices, being solution focused, our voices around designing, innovating, creating solutions. What we've had in the last 12 months probably is more some of those loggerheads where we have that intersection between GP practices, LMCs, contracting at that level. Yeah, and I think we need to respect the different places there. For the first time, we've had, action, a different kind of voice, issues over local contracts for our individual GPs, which is, we're a group of GPs that work together, but that's all kind of not been part of our federated working. So it's been a tricky territory over the last 12 months, and we hope that comes back into balance so we're less distracted by some of that real stuff and can focus more on solutions and progressing as groups of practices. But just as I've felt it, our practice, and we've seen our practices really feel it, particularly over the last 12 months, where previously it hasn't been such an issue and we've been focusing on other better things.
Where you said you've been designing solutions, can you give us some examples?
A lot of our work is in that neighbourhood, coordinating care around our frail and most complex people, and developing a neighbourhood team using the additional roles scheme to implement new services and create a new team in the neighbourhood. That's been really one of our primary focuses. I think outside of that PCN and the neighbourhood box, just simple things like working together as a group of 16 practices to do a research program is much easier to do at that scale, and we can support and manage and make it as easy as possible for practices to engage in that. And it's it brings some income where practices have been really struggling. Those kind of efforts can help us out as groups of practices. So there's different types of work that we get involved in.
How would you describe the environment and like the culture of your PCNs? And the reason why I say this, because when we did the leadership course, whilst it, from my perspective, it did feel very amicable and supportive and very friendly, but every now and again it was like, well, it's okay for like it's okay for you, Dan, because you're in a federation, like you've got that scale. So there was a difference between the PCNs and the federation, the perception of the federation.
Yeah, and I think that's my point around collaboration. How can we make up that difference? Because size is material to the organisation that you can develop that supports the good work that we do. If we look at a comparison between a federation that's been working together for a long time, supporting a population of, I think, 135,000, and what we can, I guess, the depth of our organisation to support that, in comparison to a smaller PCN that has a 30 to 50,000 population designed to deliver what's in the PCN package, there's real limits. And how do we get beyond that and support each other when we're looking at collaborating across all of our PCNs? And that was a lot of the discussions, wasn't it? Part of the reason for the alliance is, how can we develop together? How can we, as a group of PCNs, for example, offer a service in the community that's equitable across the county?
What do you mean by equitable?
So that we cover a whole population, irrespective of the resource we've got in individual areas. How can we have a look at how we can design something that is, if you like, commissionable and deliverable at that scale? When we recognise there's different priorities, different resources across our 14 PCNs, how can we take a piece of work and deliver it?
In your neck of the woods, do you feel like you've got a good relationship with your commissioners?
Yes, no, and maybe. Well, talking about that relationship being strained and tested in that environment around collective action and some of those local services has been really, really difficult between us. We've got things, we've got things wrong, but we reflect on that and look at how we make it better. I think, within of course, the limits of the funding that we've got available, we've got a good relationship with our ICB about how we develop our PCN alliance in that space, and so we can be a recognised voice, a recognised delivery partner, and that takes some work, and they're alongside of us on that. So it's a tricky balance. And then we've got, of course, we talk about activity within PCNs. We're I guess defending and supporting the stuff that should happen in practice partnerships. So we've got to get it right between the PCN modelling and the PCN alliance modelling in the relationship with our ICB and, of course, our LMC to support that and help us get it right, and all the other partners that we've got in the room. It's a tricky space to get it right and recognise where different things should be and work around the grey areas to resolve that when there might be some friction.
So where you mentioned around collective action, you got some things wrong. Can you give an example?
Yeah, I think an example is mixing up, I guess, the national view of a collective action and a view of groups of practices responding to that. It's a national collective action, not a federation that's driving that, and we just need to be careful that doesn't reflect on our relationships, get in the way of doing other good stuff. We're in tricky territory around, and it seems to be moving towards a resolve across collective action, individual practices, and some of the local enhanced services that need properly reviewing and refreshing. We're along the way of resolving that at the moment, but we can try. Relationships are really, really important. The relationships are needed to make the right decisions on how we do that work for the patients. That should be at the heart of everything that we do, of course. And when we look at what we're doing things for, we look at it from a perspective, firstly of a patient, then our individual GP practices at a federation level, and now an alliance, and delivering benefits to the system as well. We know systems are strained financially and otherwise, so they're the lenses we need to look at it through, and we need to get we need to get along so that we're able to address the benefits in each of those spaces.
In your alliance and your federation, it's a lot of it the same people, but in different capacities.
Yeah, there's certainly some different hat wearing, isn't there? Yeah, I mean our federation, I don't think we've had since 2017. I don't think we've had a a change of the board other than some additions to it. So we've got, and we've got a trusted board and a group of practices, the same practices, so some names change, but we're used to working together, and we've got I guess an all-in model for delivering shared services, whether they're in the PCN box or outside of that. So it's familiar territory for us, and the alliance is, we've seen some changing shapes in individual PCNs, boundaries and membership over time, but we've got a fairly good, that's an understatement. We've got a really good group of clinical directors that work together. We've got, as you've seen, a really good group of business managers, the PCN managers, that work together.
Do your PCN, so membership is really interesting. So do your clinical directors, so is your membership on, I don't know what board I'm talking about now, but do your clinical directors and operational managers, are they ever together in a board, or are they separated?
So we have, and we've been doing it for a while. We're formalising the arrangements as we progress. But our clinical directors meet frequently, and our PCN managers we meet frequently. We address different but same topics, sometimes through a different lens, and will bring us all together as we need to. But they're two groups that work frequently together. And so we formed an executive for the PCN Alliance that spends more time doing the work around the discussions that have had, kind of led by the clinical directors and the business managers, work from an operational and strategic perspective together on how we get things done.
I bring that up because I think it is quite common to have your non-clinical leaders and your clinical leaders separate. And what can happen is your clinical leaders make decisions, but without the understanding, in some instances, about how it's going to be operationalized. And there's opportunity, like if they just had a conversation, it would have been so much easier. But there sometimes is this divide, like you're clinical and you're at the top, and you're non-clinical and you're lower down the chain, and there is that culture there. That's undeniable.
Yeah, and we've had those discussions of bringing together. We do that. Not in every meeting. It does work well having if you like, the two need to coincide, but really close-knit operational crew that are having those discussions, and clinical directors used to working together. There is a bridge between the two. I work as part of on the executive. I join the clinical directors meetings and feed directly back, and we do bring us all together periodically rather than for every meeting.
So what does a well-functioning board look like?
I think a well-functioning board has had some practice working together and knows each other and knows the people that they're representing. To make a well-functioning board, the most important thing is trust, and you get trust, I think, from runs on the board and from delivering. We need to be really clear on where the decision making, but actually a well-functioning board, I think, has governance that works according to their governance without having to pull the rule book out at every meeting. I don't think I could count on one hand the amount of times we've had to vote with all our 16 practices and our board members, and it's representative. We've got seven on the board that is a very good cross representation of the practices. A well-functioning board has a good perspective on risk, and that's really important, I think.
And how do you communicate that risk? Give us an example.
So a good example is clinical and operational risk. I think a really good example was, it's a cliche one, go back to the old COVID, but we were in the first wave of sites going live, and it was happening very, very quickly. And there's a little bit of, if you like, slurring between policy and operational guidance. And our board has got really good clinical direction that can understand the difference and recognise that, for example, it is a service that we're delivering, and it is in our gift to operate in the best way that we see fit, recognising the clinical setting and the clinical governance. If we're following to a rule, some of the operational guidance that came through our model would have looked quite different. So we're operating, we're operating safely within the clinical guidance that we understand, and can develop an operational model on that.
Do you have physicians associates?
No, we don't.
Have you ever had physicians? I can't say physicians
Not.
associates.
I know of one practice that had a physician associate, but it was outside of our resource strategy for our additional roles scheme. So all of our resources are built around shared services across our 16 practices, and physician associate wasn't an easy fit for that, offering services across 16 practices. The only way we've had individuals supported and learning in individual practices where we took on some training nurse associates.
Okay. How have you managed the national, or potentially going to manage the national insurance increase if the R's budget doesn't increase? If I reckon it will, but if it doesn't,
yeah. So we've had a similar issue, haven't we, in this current year, where the overall cap hasn't increased.
Yeah.
But there was an expectation, of course, there's an expectation of people's roles to be progressed in line with the inflationary type uplifts we see across general practice and the agenda for change. So, so in this year, we model financially on a worst case scenario. So our model this year catered for spend of increasing pay with no increase in the overall cap. So when we've modelled for the next year in our additional roles scheme, we've modelled for, again, no inflationary increase for people's wages in that cap, and also a national insurance increase. So we work on that, if you like, worst case financial scenario, and then we adapt when the news comes out.
Do you treat your practice staff the same as your PCN staff? So did you give your practice staff 6% increase this year, or this financial year?
It's difficult. It's really difficult and tricky, and they're in different timing phases as well. So it really causes some unrest. It would be nice if it was all aligned. So you kind of got 3 points of reference, which is general practice, GP practices, the additional roles scheme, and then an agenda for change that sits somewhere else alongside of that. No, it wasn't equitable. The increase came through to individual GP practices, and they treated it. Of course, they discussed it. It's a great place to discuss that and support each other's. Discussions are had across 16 practices. Individual practices implement uplifts across the range of staff they do in their individual way. What we do is we pass on the full uplift through the additional roles scheme at the timing as which it comes, and that's as fair as we can be, we think.
Have you had challenges recruiting your additional roles?
Yeah, of course, every time. If we go beyond the challenge of finding a really good clinical pharmacist when they're in demand, if we go beyond that and look at it organisationally over time, one of the difficult things is making really good career paths within a limited structure. Yeah. So we lose people because of that, because there's opportunities to progress elsewhere that there isn't within the limited structure and hierarchy and the role scheme. What's really good is there's an opportunity now to make your own in the additional roles scheme. So actually, if we're looking at developing some of that structure in a meaningful way, there's limited opportunity to do that now. But the size and scale and the limited hierarchies we've got in individual PCNs and federations is a limit to growth, isn't it?
Do you use providers, clinical providers?
Yes. Yeah. So our view is we let our service model design determine where the best fit is for employment. Example, we have our health and wellbeing coaches employed, hosted by the organisation that's already delivering in that space in the area, and then they're embedded within our teams. We've used the first contact physio providers, particularly in the early stages. We support those local providers, but then they work under a standardised model, but predominantly they're K2 employed, but our decisions are made based on those services designs. We use some remote pharmacy across our across our model, and which gives us some more flexibility within the team. And when we're modelling, for example, on the potential of not having an increase to support wage increases and not having an increase to support national insurance uplift, it's that kind of thinking that can give you some flexibility to make the best use of the overall funds, when otherwise the conditions are permanently employed people in those really good roles.
If you were to win a HSJ award, what would it be for?
We nearly did.
What should you have won it for?
I think really our best attribute is our working in our neighbourhood working model. So we purposely designed our additional roles around a core function of coordinating care across the frail and complex group. So foundation of that model is really good care coordination. We had that in place with clinical care coordinators before the PCNs, but we've been able to build on that foundation to develop a core model of the resources that that we're able to draw down on, and working in partnership with others to have really good neighbourhood teams.
What does the future look like for you guys in an ideal world?
So I think for us, strengthening the collaboration across our PCNs. If we look from past to future, our past was 16 practices in a federation with a really good relationship with our CCG. Now we're looking at a view of doing things across a county, and to do that, we need to do that in partnership with our neighbouring PCNs. So, strengthening that model and being able to deliver together in that space is really important. I think, of course, delivering on the DES, but the PCN DES, but that compelling opportunity to do so much more in the neighbourhood space is a really good one. And of course, looking at delivering more and more services that bring in income to support the sustainability of our practices. So we talked about research as an example of really program that we do together that brings in some income. We provide services to our urgent treatment centre, into our community diagnostic centre. We provide asylum services, those type of things that aren't specified to us. More and more opportunity to do that really well in the community is where we're looking to bring in some more income to support our individual practices. And the practices are shareholders in the federation, and the good work that we can do together as an opportunity to bring income to develop the federation, but also support our practices.
What is one thing you're really struggling with right now?
That's a tricky question. I think the thing that we're working through is the conditions around contracts for individual GPs, the local contracts, the getting right the intersection between the different interests between practices and PCNs, and being able to deliver on a I guess a county-wide basis. That's, I wouldn't say struggling. We're working through to get that.
How long have you been the CEO for?
I think maybe 8 years now. Must be getting onto 8. I was brand new to the NHS back then.
So brand new, nearly 8 years in the role, CEO. What advice would you give to a new CEO or operations, a new manager coming into the NHS or coming into primary care? What top 3 pieces of advice would you give them?
I think learn your people and get support from the right places. You can't deliver it all. Can't deliver it all yourself. You might have a strategy for your PCN, but what's most important in delivering that is exchanging value across the organisations and the people that you'll be really closely coupled with. So that's probably the best advice I can.
How do you do that?
Make friends. Listen. Get the support. Spend the time to get to know the environment.
How do you win over somebody that does not want to be friends with you?
I think understand why they don't want to be friends. It might not be you. Sometimes,
no, but what if it is you?
Sometimes it's not, just be a better you. I think what's important as well, it doesn't always need to be your own voice, does it? I think use the people, address the concerns in the right way, and it doesn't always need to be you to do that. One thing that can work in your favour is simply time. Not everything needs to be fought at the time. We see conditions change, and choosing which pieces to focus on and battle is really important. Some battles don't need to be had. We need to respect the issues, but the answer isn't always to fix them.
How do you bounce back from a shockingly bad week?
I think you just got to keep going. Brush yourself up and keep going. Your friends will help you get over a bad week, I think. There's no one else going to help you other than yourself and the friends that you've got around you.
I mean, maybe this is not a good question to ask you because you're pretty laid back.
Yeah, my wife won't tell you that. She knows me better. I hide it well.
Thank you so much. I really appreciate your time. I think it's our audience loves to hear what other areas are doing, and I think those in primary care will absolutely be able to resonate with what you're saying. And I think there's also what you're saying and what you've not said.
Mm-hmm.
You're good at that. Well, hopefully I'll speak to you soon. Thank you so much.
Lovely to see you. Thank you.
Okay, right now.